Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. Today's episode features coverage of new data from the 4th HIV Research for Prevention Conference, or HIVR4P virtual. During this podcast, Dr. Linda-Gail Bekker, Director of the Desmond Tutu HIV Center in South Africa, will discuss important new findings presented at the conference, including results from studies evaluating novel approaches to HIV prevention, such as broadly neutralizing antibodies, long-acting injectable and oral antiretrovirals, and implantable options. In addition, Dr. Bekker will discuss several studies evaluating different aspects of PrEP implementation and acceptance, as well as considerations for multipurpose prevention strategies. For more information on Dr. Bekker and for a link to additional online CCO coverage of HIVR4P virtual, including a downloadable slide set covering the studies discussed in this episode, please visit the show notes. Now let's get started and hear what Dr. Bekker has to say about these new data.
Hello, everyone. Real pleasure to join you to look at these rather exciting studies that we've selected from the recent HIVR4P virtual. In this session, we hope to cover a series of interesting studies. One, first of all, looking at a proof of concept study known as AMP, or antibody-mediated prevention. We'll then go into a couple of studies looking at antiretroviral based PrEP and some new findings in a phase 3 as well as in a phase 2A. We'll look at interesting and exciting new developments for ARV-based PrEP in a study looking at implants in macaque monkeys. We turn our attention then to PrEP implementation issues, particularly around PrEP initiation in pregnant women, patterns of sexual behavior around the COVID-19 restriction, and attitudes and use of event-driven PrEP amongst MSM in the US. Finally, to round it out, we'll look at new innovation in multi-purpose prevention technologies, on the one hand for cisgender women, and on the other hand for substance users. And our final slide of the day will cover new antiretrovirals for pre-exposure prophylaxis. So let's hit the road. So the first study that I think really brought a great deal of discussion and interest at R4P involved this concept of using biologicals, antibodies, as passively transferred as an injectable to see if they could prevent the acquisition of HIV. And this involved two studies, one known as HVTN703 and the other one HVTN704, one in cisgender women in sub-Saharan Africa and the other amongst men who have sex with men and transgender persons who have sex with men in America and Europe. And as mentioned, explored whether VRC01 as the first proof of concept monoclonal antibody might be able to prevent HIV acquisition using two doses, 10 milligrams per kilogram and 30 milligrams per kilogram versus a placebo control every 8 weeks for 10 infusions. And efficacy was tracked through week 80. We also get safety and tolerability all the way out to week 104. So in this slide, what you see, and these are the important findings, is that it is absolutely critical that the monoclonal antibody and the circulating HIV virus that may be infecting somebody are well matched. In other words, that the virus is sensitive to the monoclonal antibody. And much like we see with vaccines and with our own immune responses, it's very important that this sensitivity is in place. And if that sensitivity does not exist, in other words, if resistance has been developed by a circulating virus against the monoclonal antibody, then the efficacy is lost. So overall in this study, we see that actually we had no efficacy demonstrated. And this was because only 30%, 1/3 of the circulating strains were sensitive to the antibody VRC01. And here you see the data in the slide. It's also important to note that the monoclonal antibodies, like active vaccines and our own immune systems, can put immunological pressure on the infecting viral strains. And this slide really goes into that detail to show that we saw more resistant strains in the participants who received VRC01, suggesting that actually it was this immune pressure that resulted in the viral resistant strains, which then allowed infection over time. So the conclusions we draw from this is that viruses can be readily neutralized in vitro, can be blocked from transmitting HIV in vivo with a single bNAb. So we do have proof of concept. We know in 30% of the participants, HIV acquisition was prevented. Good to hear that there are multiple new broadly neutralizing antibodies that have greater potency, breadth, and duration coming down the pike. And we are expecting these future efficacy trials will be coming into the clinic soon. Moving along now to the exciting phase 3 that was discussed in great detail at R4P. This is HPTN-084, a long-acting cabotegravir-based PrEP agent versus what we are more familiar with, FTDF, as an oral agent. And as mentioned, this was conducted among cisgender women in sub-Saharan Africa. The age group concerned was 18 to 45, and there were more than 3,000 participants. And in the first step, women were introduced via oral medication and then transferred by week 5 to the long-acting cabotegravir. Everybody received an injection and everybody received a pill. This was a double-blind, double-dummy design. And the primary endpoint was a superiority analysis of HIV incidence during steps 1 and 2. Following the study completion, or when people followed the active follow-up, they were then transferred all onto oral TDF FDC. There was a pre-specified stopping boundary, which occurred after a certain number of endpoints had been accrued, and this happened in November the 5th, 2020, last year, and we saw the data shown in detail. It had been released as a press release, and the data is shown here. A paper will be forthcoming, and we saw a little more data included, which I'll show in the next slide. Here we can see the incidence. The first point to make is that overall incidence was much lower in this whole cohort than has previously been seen in cisgender women from sub-Saharan Africa. So round about a 1.03 pooled HIV incidence in the cohort, which is excellent. But then really the very good news is to see how the Kaplan-Meiers between the CAB-LA and the oral TDF, how they separate. And what we saw there was a 9-fold reduction in HIV acquisition in the women who were on the arm a long-acting cabotegravir. So we definitely see a superior outcome in terms of CAB-LA amongst these women. Importantly, there was a similar safety profile, both drugs very clean and easy to take. No adverse events that really come to mind. There was no difference in STI incidence, pregnancy incidence, or overall weight gain. And of course, this is an integrase inhibitor, so we are watching weight gain as an issue. And there you see all the more than grade 2 AEs. And importantly, we have to look at injection site reactions. And again, of course, the CAB-LA, in this case, having a greater percentage of injection site reactions, but no discontinuations. So really not so significant that it resulted in discontinuations. So let's keep moving. The other study of importance was a phase 2, so looking at safety and PK of a new agent, exciting agent called islatravir. It's an NRTTI. This is a common, a new modality, a new type of antiretroviral, and it is coming to us as PrEP and as treatment. This study looking at, in a phase 2, a blinded interim analysis of a randomized double-blind placebo-controlled phase 2A trial of once monthly oral islatravir in adults at low risk. So importantly, a once a month pill. And the first thing you see from the data here is there's an extraordinary long half-life of this agent. It is very potent. It was studied at both 60 milligrams and 120 milligrams daily. These results showed observed concentrations in PBMCs that correlated well with population pharmacokinetics, and pharmacokinetics really measuring up well to linear dose proportionality. So very clean drug, well behaved. And although we didn't see the tissue PK, we had a suggestion that it is also very good at the target tissues. Importantly, looking at safety, most AEs were mild or moderate and resolved on treatment, no serious AEs or deaths, and very exciting that this once a month, 12 pills a year, intervention will be coming to us in a phase 3 in women who have sex with men. That is in starting in the US, but also here in sub-Saharan Africa, starting in Q1 of 2021, but also to be studied in men who have sex with men and transgender people. So watch out for that drug. Keeping on the theme of antiretroviral-based new PrEP, we want to also deliver these agents via implants, and there are a number of implants in design and development at the moment, one containing TAF as a close cousin of TDF. So that we'll describe that study in a moment, but we know also there's a Caballet implant coming as well as an islatravir implant. But this study from the R4P conference was in macaques. So it's a SHIV bundle looking at inserting the TAF implants into the macaque over the period shown here, week 0, the implant being inserted, and then over a period of time, SHIV infections being the macaques being exposed to a number of SHIV doses. Finally, on week 8, removing the implant, and then a follow-up period. So let's look at the results there. Very exciting. All 6 macaques with implants were completely protected, whereas 7 out of 8 of the controls became infected. So it does look like very high sustained TDF DP levels are tenofovir DP levels are maintained through this process. Unfortunately, we do have a bit of a drawback in that when the implants were removed, there was evidence of necrosis at the site of the implant. So it does look like we're going to have to look a little harder about how to manage that. Let's turn to some of the implementation science aspects. And this study was carried out in pregnant women in South Africa. So PrEP in pregnant women, a good number, 712 pregnant women. They were followed up through 12 months postpartum. And we're going to look at 2 aspects of these women. First of all, their uptake, their persistence, and their adherence. So, excitingly, more than 91% of women were keen to get involved. These were high-risk women, high rates of STIs. The STI diagnosis was very much associated with a higher likelihood of PrEP initiation, whereas marriage and high reported PrEP stigma were barriers to initiation. Factors associated with persistence, which was defined as returning for repeat PrEP after baseline, and with adherence defined as self-report of taking PrEP more than 5 of 7 days prior to the visit, were associated with the following factors. So first of all, postpartum versus pregnant women had a lower odds of PrEP persistence and adherence, and you see the odds ratios there. On the other hand, higher education level and lower gestational age were associated with better PrEP persistence and adherence. Please note that 24% of women reported AEs. They were mild, but some of them difficult to disentangle from typical first trimester pregnancy problems. Here's another study in Dutch MSM. It's known as the AMP PrEP study. And this was a prospective study in this cohort of MSM and TG persons at an STI clinic in Amsterdam, looking at the following endpoints. The aim was, first of all, to evaluate how sexual behavior and use of PrEP and condoms changed following COVID-19 restrictions. And the endpoints here were the proportion of days with anal sex before versus after restrictions, the proportion of anal sex with PrEP or condom use before versus after restrictions by partner type, and then a comparison of changes to a previous year in the same cohort. And you see when the various restrictions occurred in Amsterdam there. So let's turn to the results. Here you see in this table sexual behavior, use of PrEP or condoms by partner type before versus after COVID-19 restrictions. And we're looking at the proportion of sex days, PrEP use, condom use, whether they were a steady partner, a known casual partner, or an unknown casual partner. And what you can see here is that all changes in proportion of sex days were transient regardless of partner type. Compared to the prior year, the changes in proportion of sex days most differed with known casual partners, and the changes with steady and unknown casual partners more pronounced than similar pattern which was exhibited around the time in the prior year. Individual use of PrEP per day was significantly decreased after restrictions, so from 74% to 58%. And there was a lot at the HIVR4P meeting around the impact of COVID on HIV services. And of course, PrEP, a very important part of those services. But I think important to understand also patterns of sexual behavior during these periods of restriction. What about event-driven PrEP? So this has now for some time been in the guidelines as acceptable for men who have sex with men, and it is not yet recommended for women who may be exposed to HIV via the vaginal route. So it is important to know that this is recommended more for anal exposure, anal route exposure. And this is a survey of MSM without HIV infection from 2 US cohorts, looking in particular at attitudes towards event-driven PrEP after receiving visual and written descriptions. So the 2 cohorts in question are the RADAR cohort, consisting of about 424 people analyzed here, although the cohort is bigger and in Chicago. And then a national online survey, again, 267 people surveyed and reported here. This was conducted through social media. The survey items in question was awareness of ED PrEP before the survey, interest as indicated by preference for daily versus event-driven, and current use of PrEP. And then, of course, the eligibility for event-driven PrEP determined using WHO guidelines. And you can find those on the website, on the WHO website. So let's look first at awareness, interest, and use of event-driven PrEP amongst these individuals. So you see the 2 cohorts, RADAR and the National Online Survey, preferences for event-driven, and then eligible for event-driven. And you can see really rather low preference despite the fact that many more individuals were eligible. It's important to note the radar cohort was younger, less sexually active, and more racially diverse. So there's no doubt we do need more awareness creating around this concept of event-driven PrEP, because many men do describe that as quite liberating and another option, if you like, for pre-exposure prophylaxis. What are the new innovations coming down the line? And definitely for cisgender women, this concept of multi-purpose technologies is an important one. It doesn't only apply to sexual and reproductive health, of course, and we'll come on to how it can be used in other ways. But within the context of sexual and reproductive health, it's important for us to think about STIs, contraception, as well as HIV acquisition prevention. So here you see a number of different options in clinical trials, phase 1, 2, and 3, doing a variety of contraception, STI prevention, and HIV. So an exciting area to watch, and definitely I think something that will be looked forward to in the future. What about for substance users? And we do know that opioid agonist therapy is part of the package that we should be supplying to people who inject drugs, as well as syringe services, HIV treatment as prevention, and of course PrEP. So all of the above have prevention strategies with synergistic effects. And the recommendations, certainly for OAT, is that it is effective, reducing overdoses by more than 3-fold, but also reducing HIV and HCV. OAT in people who inject drugs is associated with increased antiretroviral use, better adherence, and viral suppression. And OAT does not eliminate HIV transmission due to treatment interruptions, suboptimal dosing, and polysubstance use and sexual risk in some people. So it is important to think about these various modalities and use them for synergistic effects. We do know, however, that in contrast, people who inject drugs are often undertreated for HIV, and PrEP use is almost non-existent due to stigma, multiple clinic visits, our own prejudicial sort of ideas about this, and in many parts of the world, policy, laws, and ideologies. But we know also that when we integrate care for people who inject drugs that combine the modalities I've just described, we see synergistic reductions in HIV transmission and drug use. So long-acting treatments are another option here because of the persistence issue and the difficulty with adherence. So similar that we will be able to offer something like cabotegravir long-acting, rilpivirine long-acting combined for treatment, but also cabotegravir long-acting, hopefully in the near future, for PrEP. And for opioid use disorder, there are long-acting OAT agents coming along, as well as implantable naltrexone and probutene, who have to be thought about and considered in this population. My last slide is about this very exciting new antiviral agent. It is a long-acting HIV capsid inhibitor. It is being developed for both treatment and prevention, and we saw the mention of it again at ARVs4P. Importantly, this has a really extended use. It will be studied later in this year in a group of people, cisgender adolescent girls and young women, and cisgender men who have sex with men, as well as transgender women. These studies will begin mid to late 2021. And what I want to point out to you is that a single injection of this long-acting antiretroviral will have to be repeated only after 6 months. So a 6-monthly formulation. So very exciting. And I think look out for this and watch its progress. And with that, I will end. Thank you very much indeed, and look forward to your questions.
Thank you very much, Dr. Bekker. We have had some questions, and so we'll move into the Q&A session now. The first question we've had is from Jane. She asks if you can define ED or event-driven PrEP. Are you referring to 2-1-1 dosing?
Yes, thank you. Thank you very much, Jane. You're quite right. Event-driven means at the time of coitus, at the time of actual sexual event, and our prescribed approach to that is to take 2 doses of the oral agent, whether it's FTAF or FTDF, 48 hours before sex, then follow up with a single pill after 1 day and a single pill after a second day. So the 2-1-1 regimen, as you suggest.
Great. Okay, the next question is from Alberto. He has a question about HPTN cabotegravir PrEP study. Was the adherence measured in the oral PrEP arm?
Yes, and I think that is the clue to why cabotegravir may have been superior to the oral FTDF. So unfortunately, as we often see, although adherence started off really, really well and actually was relatively well maintained throughout, we do see that kind of falling off over time. So people really do struggle to maintain. And remember, we're asking women to take 5 out of 7 doses, 6 out of 7 doses. And what we found here was that over time, that adherence fell off. And I think that accounts for I don't think there's any difference in how efficacious these antiretrovirals are as PrEP. But I think what we see there is a difference in adherence, effective use. So thank you for that great question.
Great. Okay, the next question, Chelsea asks, are you able to shed light on any plans for cabotegravir and islatravir implants for PrEP?
Yes, I think, the exciting thing is they're both in development. We did see a study at R4P of the CAB implant, and exciting to see that is moving along. The islatravir implant, I think, is a little further behind, although you can look up the study that was presented at Mexico in 2019, and that showed the PK data. So we already have that sort of early phase 1-2 study done, and we know which dose it is we need to develop for the islatravir implant. And in fact, I know that the company that is developing that is using their contraceptive platform to develop this further. So I think watch this space. The exciting thing about the implants are, of course, they can be removed. So they are reversible in terms of their impact. And so I think a very exciting modality to follow up with. So thank you for that question.
Great. The next question is from Fernando, who asks, are there any concerns with the use of 6-monthly formulations for PrEP in light of increased numbers of sexually transmitted diseases? And the participant notes is particularly in cities like New York.
So, the question of sexually transmitted infections and PrEP has really raged in the last little while. And, and I think it's gone from controversial to being just a recognition that there are, the good thing about PrEP is that it raises the question of sexually transmitted infections. And I think for some time now, we have known that around the world, effectively, globally, STIs have been on the increase. So in many minds, the important thing about PrEP is that it brings people into the clinic. It enables that opportunity to discuss sexual health and STIs, and it raises the question of whether any symptomatic or even asymptomatic STIs may be present. And, we are talking about pharyngeal, anal, rectal, a variety of problems around sexual health that I think have been really not necessarily exposed and dealt with as much as they are perhaps in our PrEP era. Now, this question in particular, I think it's a good one, is where we reduce the number of visits, because we're now having less frequent dosing of PrEP, which on the one hand makes adherence more likely. Are we going to see these folk less often in our clinics, and does that raise issues? I think we're going to have to see how this plays out over time. And, I think we're going to have to figure out, certainly in my part of the world, in sub-Saharan Africa, where I come from, we are frantically now trying to understand how frequently we should be testing for both asymptomatic and symptomatic STIs. Up until now, we've used syndromic management, and clearly we do need to understand better how frequently we should be testing for STIs and how better to manage. So it may be that, reducing the visit schedule may fit in very well with exactly how frequently we should be testing for STIs. Obviously, with the understanding that if somebody has an intercurrent infection, that they can drop in and have that sorted out. But I agree with you. I think this is an area of implementation science still. And I think there is still work to be done, although there are some standard recommendations out in the field. And obviously we need to look at those and adhere to those. I think actually this is still an open question for a more investigation. Thank you.
Great. Thank you. A participant asks if you can speak to any differences between the long-acting cabotegravir potential option versus the oral FTC TDF in patients with HBV co-infection, or I guess I should say HBV infection, because it would be PrEP, so there wouldn't be HIV infection, right?
Yeah. So I guess just to put everybody on the same page, the issue with the TDF-based PrEP and treatment is that, of course, we share that with it being a treatment with hepatitis B. So when we treat or we use a modality for prevention that uses the TDF platform, we then at the same time provide treatment for hepatitis B. Now, obviously, if somebody is not hepatitis B infected, that's not a problem. But if they already have hepatitis B monoinfection in the case of PrEP, or they have it as a dual infection in the case of treatment, then we need to be aware of that. So recommendations are to screen for hepatitis B. Where somebody is non-immune, it is good practice to offer vaccination. But where somebody is already infected, then the important thing is to know whether there's active disease, whether that person has issues, and whether that person needs further management of their hepatitis B. If not, then, we continue with the TDF treatment. The same applies in terms of PrEP. If somebody has got TDF infection and they're not exhibiting any disease or reasons for referral or management, then we do suggest in the risk-benefit ratio that if they require PrEP, if they would benefit from PrEP, they should be offered PrEP. It is recommended that individuals get followed up for their hepatitis B, particularly if the PrEP should be stopped for some reason. But the theoretical concern of a flare at the time of stopping PrEP was very much on our minds in the early days when we started to do oral TDF type PrEP investigations, but that really hasn't played out as a major problem in practice. So I would say that along with recommendations, if the client in front of you would benefit from PrEP, even if they have monoinfection with hepatitis B, you should press on with the TDF based oral PrEP. Obviously, when cabotegravir long-acting comes through, the option for using an integrase inhibitor, which doesn't have an impact on hepatitis B, would be another option.
Great, thank you. Okay, I think this is our last question coming up here. A participant asks about any concerns or thoughts about the potential risk of, excuse me, a sneeze, of introducing integrase resistance mutations into the community with the use of a single integrase inhibitor as PrEP, and will they be looking at that in the study?
Jennifer, great question. We were all hoping that we would see some resistance data at HIVR4P. We know that the sister study, brother study, whichever way you want to look at it, HPTN-083, which was conducted in a number of countries around the world, including actually in Africa, that was conducted amongst monosex with men and transgender people. That study is also reading out about its resistance profile. We know that we'll be getting similar results out of cabotegravir, out of HPTN-084. And clearly there is some concern about, as time progresses and the dose of Cabolet reduces in the bloodstream over time, as people come off Cabolet, is there a risk of resistance? But I think this is an important question to take in the context of treatment versus prevention. So we have not really seen resistance becoming a major problem with pre-exposure prophylaxis. And the main reason for this is that if somebody is uninfected and they use their PrEP well, they are unlikely to become infected. Therefore, the risk of resistance is low. If they become infected, it's probably because they haven't been using their agent well. And therefore, again, the risk of resistance is low because they just don't have the drug around. So we need drug in suboptimal doses with a replicating virus to incur resistance. Now, it is important to note that when people come off cabotegravir, there is going to be, because of the PK, a long tail. And we don't yet really know in detail what the impact of that is going to be. And yes, it is being studied because it is a very important question. Now, you saw in the design, in the clinical trials, we've covered that tail with oral FTDF. And clearly that adds a huge logistical element to the use of Cabolet. And so I think, again, we should expect more precise implementation science to help us figure out how to use Cabolet to start it and stop it safely. And really make the most use of this exciting new PrEP innovation. So thank you very much. And with that, I'll end.
Great. Thank you, Dr. Bekker. And thanks to listeners for joining in. As a reminder, to view the full HIVR4P virtual conference coverage program on the Clinical Care Options website, click on the link in the show notes. Please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.